I'd like now to introduce Kana Hayashi, who we're very lucky to have replacing the speaker who was unable to attend from Vietnam. Kana is working with the British Columbian Centre for Excellence in HIV/AIDS for the past 5 years and is currently working on the Mitsampan study, which is a leading community-based research project on people who inject drugs in Thailand. Thank you, Kana.
Okay, thank you. I thank the organizer for giving me the opportunity to do this presentation today. It's my pleasure to be here. I'd like to start by acknowledging my colleagues and co-authors who are listed in this slide, who have contributed to the series of study findings that I'm going to present today. As a way of background, I think a lot of people may know, but Thailand has been contending with a long-standing epidemic of HIV among people who inject drugs. This graph shows the HIV prevalence by key affected populations. As you can see, the blue line represents the HIV prevalence among people who inject drugs, and it remains very high, between 30 to 50% for over 2 decades. Meanwhile, Thai drug policy is known as very punitive and then relies on drug law enforcement. And famously, back in 2003, the government implemented a war on drugs campaign, which has resulted in widespread human rights violations. Behind this drug policy, there is a key law introduced in 2002, which is called a Narcotic Addiction Rehabilitation Act. This law reclassified people who use drugs as patients and not criminals. And under this law, people who are arrested for drug use and then possession of the small amount of drugs will be assessed and then sent to rehabilitation centers instead of prisons to help them stop using drugs. It sounds nice, but in reality, there are a lot of problems with this system. For example, a lot of these centers are actually run by military, and their programming focused on physical exercises, religious activities, and therapeutic community work, but little in the way of evidence-based addiction treatment. And in recent years, there have been more and more emphasis on utilizing this system of compulsory drug detention in Thailand. For example, in 2009 to 2010, the government introduced a policy and targeting 300,000 drug users to be placed in drug treatment and primarily compulsory drug detention centers. And in 2011, the number has increased to 400,000. So despite the concern that this system of compulsory drug detention may be the key factor shaping the HIV risk environment among people who inject drugs in this setting, there has been very little research on this topic until recently. Therefore, in 2008, we launched a Mitsampan community research project, which is a collaborative research effort involving these academic institutions and the community-based organizations listed here. Especially Mitsampan Harm Reduction Center is a peer-run drop-in center for people who use drugs based in Bangkok. This project is a serial cross-sectional mixed method study designed to examine drug use patterns, HIV risk behavior, and access to harm reduction and other health services among people who inject drugs in Bangkok. The key feature of that project is taking the community-based research approach, and a total of 32 former and active drug users were trained as peer researchers, and these peer researchers were involved in all stages of the project. To date, we have conducted 3 waves of survey, and then we reached in total more than 700 people who inject drugs in Bangkok. People who inject drugs at least once in the last 6 months were recruited through peer-based outreach and word of mouth, and the picture above showing the peer outreach workers. And we conducted peer-administered interviews at the drop-in centers as shown in the picture below. And in 2011, we also conducted 48 in-depth qualitative interviews. Now I'm going to present a series of study findings about compulsory drug detention centers, but because there are so many studies, so I'm going to try to go them over very quickly. So we began by looking at the link between the compulsory drug detention exposure and the experience of police misconduct and violence. This first study, we found that almost half of our participants reported having had drugs planted on them by police. And this experience was independently associated with having been into compulsory drug detention. And likewise, in this study, we looked at the rates of police having beaten by police, and we found as high as 38% reported police beating. And again, this experience was independently associated with having ever been in compulsory drug detention. Currently, we are still doing the analysis of the qualitative data, but preliminary results show that they're having a lot of accounts of violence and neglect happening in the compulsory drug detention centers. For example, this participant is telling us that they did not provide any therapy. They just brought us into an environment that was like torture. As soon as they arrived, they just shoved us and kicked us behind bars and left us there without doing anything. I suffered withdrawal symptoms. I couldn't sleep, couldn't eat, and threw up whatever I ate. Also, an HIV positive participant told us that he was denied accessing HIV treatment while he was in a compulsory drug detention center. Well, in this study, while our data are limited in that all our participants are engaged in active injection drug use in the last 6 months, we sought to examine the impact of compulsory drug detention exposure on the intensity of drug use upon release. We found that nearly all of those who had been into a compulsory drug detention center had injected in the past week, and there was no difference in the intensity of drug use between those who had and had not been to a compulsory drug detention. Further, again, preliminary results from the qualitative study suggests that probably the compulsory drug detention center is not helping people stop using drugs, but rather making them engaged in drug use more heavily because the environment in the compulsory drug detention center are so stressful, so punitive, so that upon release, people just want to go back to drug use immediately. Further, in this study, we looked at the impact of compulsory drug detention exposure on the healthcare access. We found about a quarter of participants reported actively avoiding accessing healthcare due to their drug use. Again, having ever been in compulsory drug detention was independently associated with active avoidance of healthcare. Lastly, this is a study led by my colleague, Dr. Nadia Fairbairn. It's currently under review. And in this study, we sought to explore the association between compulsory drug detention and injection drug use cessation and relapse more in depth. For this study, we asked participants about the longest time period that they consecutively stopped injecting. And then about half of the participants reported they stopped injecting for greater than 1 year. And about 22% told us that they stopped injecting between 3 and 12 months. And the rest of the participants stopped injecting less than 3 months or never stopped. So having the last category of people as being the reference category, we examine the factors associated with a long-term and short-term injection drug use cessation. The first model, looking at the long-term injection cessation, A number of factors were found to be independently associated with the long-term cessation of injecting, including incarceration and voluntary drug treatment being the top two strongest association with the long-term cessation. The model 2, looking at the short-term cessation of injecting, again, incarceration and voluntary drug treatment enrollment were positively and independently associated with the outcome, and as well as nearly as strong association was found with the compulsory drug detention exposure. And then interestingly, and then unfortunately, people who have ever received methadone treatment were less likely to stop injecting for 3 to 12 months. In a sub-analysis, we also asked participants for reasons for injection cessation. The most commonly mentioned reasons was that becoming incarcerated, and 10% of the sample also mentioned being sent to compulsory drug detention center. We also asked about the reasons for relapse into injecting. Again, being released from prison or compulsory drug detention was the most commonly mentioned. In summary, we found that there's a strong association between a long-term cessation of injection drug use and incarceration. This finding may likely reflect lengthy sentences for drug offenses in Thailand. And importantly, compulsory drug detention was associated with short-term cessation of injecting, but not long-term cessation. And also, compulsory drug detention was mentioned as the most common reason for relapse. Given that compulsory drug detention typically consists of 5 to 6 months of detention, these findings may suggest that people may stop injecting while they're in a compulsory drug detention, but probably relapse into injecting relatively immediately upon release. And this interpretation was consistent with the other study findings I just presented. Lastly, as expected, voluntary addiction treatment appears to be promoting cessation of injecting, but unfortunately, methadone treatment was not. And this may likely due to the well-described deficiencies in the Thailand methadone program, including low dosage and providing methadone as not as a maintenance, but as part of the tapered detox. In conclusion, a series of our study findings suggest that the Thailand's compulsory drug detention system may not be meeting its basic objective of helping people stop or reduce their drug use. Rather, this system is associated with various forms of police misconduct and violence, and probably impeding with the HIV prevention and treatment effort among people who inject drugs. Further, this system may be deterring people who inject drugs from accessing healthcare by perpetuating stigma and shame. Therefore, as consistent with the recent recommendation of the 12 United Nations agencies, the system of compulsory drug detention should be replaced with voluntary evidence-based harm reduction and addiction treatment programs in community settings. I'd like to finish my presentation by acknowledging all the people who contributed to the research. More information can be found on our website. Thank you.